2 pills, same job, but for seniors over 65, one carries risks, the other doesn't. And most doctors haven't told you which is which. Lisinopril is one of the most prescribed drugs in America. Tens of millions of people take it every single day. It has been the default blood pressure medication for over 3 decades. Cheap, generic, and everywhere. But new research published between 2025 and 2026 is forcing cardiologists to ask a question they avoided for years. Is Lisinopril actually the right choice for patients over 65? Then, on January 14, 2025, the American Heart Association updated its prescribing guidance, flagging age-related tolerability as a critical factor in the ACE inhibitor versus ARB decision for the first time. That single line in a clinical guideline document is quietly reshaping how cardiologists think about tens of millions of prescriptions. Its quieter rival, Losartan, targets the same biological system. It achieves the same blood pressure control. But the side effect story is very different. And for seniors, that difference can mean the gap between staying home and ending up in a hospital. By the end of this, you will have cardiologist-backed data, real numbers, and a clear answer. Here is something your doctor probably never said out loud. Your kidneys lose roughly 1% of their filtering capacity every single year after age 40. By the time you reach 65, that loss is measurable. It is clinically significant, and it changes everything about how blood pressure drugs behave inside your body. Think of the aging cardiovascular system as infrastructure that has been under pressure for decades. Arterial walls stiffen, they lose elasticity. The smooth muscle that once allowed vessels to dilate and contract with precision becomes rigid, calcified in places, slow to respond. Blood pressure medications that work smoothly in a 45-year-old vascular system interact very differently with the stiffer, less responsive vessels of a 75-year-old. The same dose, a completely different effect. The same pill swallowed at the same time each morning, landing in a body that processes it at a fraction of the speed it once did. Picture a garden hose that has been left in the sun for 20 summers. The rubber has hardened. When you increase the water pressure, the hose does not flex and absorb the surge the way a new hose would. It transmits the force directly, rigidly, to every connection point along its length. That is what happens inside aging arteries when a blood pressure medication hits the system too hard, too fast, or lingers too long because the kidneys clearing it have slowed down. The drug does not behave the same way. The plumbing has changed. Then there is the metabolism problem. Seniors process drugs more slowly. The liver and kidneys clear medications at a reduced rate. That means standard doses can accumulate. Plasma concentrations climb higher than intended. Side effects that a younger patient barely notices can become genuinely dangerous in an older one. What registers as a mild headache at 45 can manifest as dangerous hypotension at 75. A blood pressure drop that sends a 45-year-old to sit down for a minute sends a 75-year-old to the floor. The pharmacology doesn't change, the patient does. And most seniors are not taking just one medication. The average person over 65 takes 5 or more prescription drugs simultaneously. Every additional drug multiplies the risk of interactions. Blood pressure medications sit right in the middle of that web. They interact with diuretics, with NSAIDs, with potassium supplements, with the diabetes medications that so many hypertensive seniors are also managing. The complexity compounds with every added prescription. What looks like a clean, well-tolerated drug in a clinical trial of otherwise healthy middle-aged adults looks very different inside the body of a 71-year-old managing hypertension, type 2 diabetes, osteoarthritis, and early-stage chronic kidney disease all at once. The 2025 American Heart Association guidelines address this directly. For the first time, they explicitly flagged that the choice between an ACE inhibitor and an ARB must account for age-related tolerability, not just efficacy, tolerability. That is a meaningful shift in language from one of the most authoritative bodies in cardiovascular medicine. It signals that the field has moved past the assumption that what works in a 50-year-old clinical trial population translates cleanly to a 72-year-old managing 4 other conditions. This is the landscape Lisinopril and Losartan compete in, and the stakes for getting the choice wrong are not abstract. They show up in emergency rooms. They show up in fracture wards. They show up in the quiet devastation of a family that didn't know the risk existed until it was already too late. It was 1987, and Lisinopril was entering the American market as one of the most promising cardiovascular drugs the FDA had approved in years. The scene is a pharmaceutical landscape still dominated by older drug classes: beta blockers, diuretics, calcium channel blockers, each with their own limitations, their own side effect profiles, their own patient populations where they simply did not perform well enough. Cardiologists were looking for something cleaner, something that targeted the underlying mechanism of high blood pressure with more precision. Lisinopril arrived as exactly that. The drug belongs to a class called ACE inhibitors. ACE stands for angiotensin-converting enzyme. Here is what that means in plain language. Your body produces a hormone called angiotensin 2. That hormone is a powerful vasoconstrictor. It tightens blood vessels. It tells your kidneys to retain sodium and water. Both of those effects drive blood pressure up. The enzyme that creates angiotensin 2 is the target. Lisinopril blocks it. Block the enzyme, you block the hormone. Block the hormone, blood vessels relax, the heart works less hard, blood pressure drops. It was elegant, it was mechanistically precise, and the clinical results backed it up. Within a decade of approval, Lisinopril had accumulated a body of evidence that most drugs never achieve. It lowered blood pressure reliably across a wide range of patients. It reduced the risk of heart attack. It reduced the risk of stroke. But the finding that truly cemented its dominance came from diabetic patients. Lisinopril demonstrated a measurable protective effect on the kidneys in people with diabetes-related kidney disease. That was enormous. Diabetic nephropathy was and remains one of the leading causes of kidney failure in the developed world. A blood pressure drug that also slowed kidney damage? Cardiologists and nephrologists both had reasons to prescribe it. The prescribing numbers reflected that. By the early 2000s, Lisinopril was not just popular, it was the default. Physicians reaching for a first-line hypertension drug reached for Lisinopril almost reflexively. The reasons were straightforward. It worked, it was generic, it was cheap. A month's supply could cost less than $4 at major pharmacy chains. For health systems managing large patient populations, cost-effectiveness mattered enormously. Lisinopril checked every box. What comes next is the part that still doesn't make sense, at least not until you look at the data that was quietly accumulating in the background. Because even as Lisinopril was being prescribed to tens of millions of patients, a specific side effect was showing up with stubborn consistency: a dry, persistent cough. Not dangerous in most cases, not life-threatening, but relentless. Studies put the incidence somewhere between 10 and 30% of patients. Some estimates go higher. That means somewhere between 1 in 10 and 1 in 3 people who took Lisinopril developed a cough that would not go away. A cough caused by the drug itself, triggered by the accumulation of a compound called bradykinin, which ACE inhibitors allow to build up in the lungs. For a 35-year-old, a persistent cough is annoying. For a 70-year-old with existing respiratory issues, or a patient already managing chronic obstructive pulmonary disease, or someone whose sleep is already fragmented by pain or nocturia or anxiety, that cough is a serious quality of life problem. It leads to discontinuation. It leads to patients stopping their blood pressure medication entirely rather than enduring the symptom. And a patient who stops their antihypertensive because they cannot tolerate the side effects is a patient whose cardiovascular risk climbs back up. The prescribing community knew about the cough. It was documented. It was discussed. But for years, the calculus remained the same. The drug worked. It was cheap. The cough was manageable for most patients. Keep prescribing. A drug that costs $4 a month and has 35 years of safety data behind it is a very hard thing to move physicians away from. So yeah, not great, but not enough to change the standard of care. Not yet. If Lisinopril had stopped accumulating concerning data points here, this would be a very different story. The cough alone might never have been enough to shift prescribing patterns for seniors, but the cough was not the only issue. There was another risk, rarer, far more serious, and in older patients far more dangerous. That $4 price tag and 3 decades of prescribing inertia would come back to haunt Lisinopril. But that's getting ahead of the story. The year is 1995. The pharmaceutical landscape is shifting. A new class of drug is about to enter the market, and it has its sights set on exactly the same target as Lisinopril. Scientists at DuPont Pharmaceuticals have been working on a problem for years. Lisinopril blocks the ACE enzyme. That much is established. But blocking an enzyme is a blunt instrument. The body has backup pathways. Angiotensin II, the chemical that tightens blood vessels and drives blood pressure up, can still be produced through alternative routes. The enzyme block is not airtight. Researchers know this. And they start asking a different question. What if you don't block the factory? What if you block the loading dock? That question leads to Losartan, FDA approved in 1995, the first angiotensin receptor blocker, an ARB, ever cleared for clinical use. It doesn't touch the ACE enzyme at all. Instead, it goes straight to the angiotensin II receptor, the specific docking site where angiotensin II lands and triggers vasoconstriction. Losartan occupies that receptor, blocks it. Angiotensin II is still produced, still circulating, but it has nowhere to go. The signal never arrives. The blood vessels don't constrict. Pressure falls. If that sounds like a minor technical distinction, keep watching, because the mechanism difference is not just academic. It has real, measurable consequences for patients. And one of those consequences is about to rewrite the prescribing conversation for millions of seniors. Here is the critical distinction. When lisinopril blocks the ACE enzyme, it doesn't only stop angiotensin II production. ACE is a promiscuous enzyme. It breaks down multiple compounds in the body. One of them is bradykinin. When ACE is blocked, bradykinin accumulates. It builds up in the lungs, it irritates bronchial tissue. It causes a dry, persistent, maddening cough. That cough affects up to 30% of patients on ACE inhibitors. And in seniors, as we will see, the consequences of that cough go far beyond discomfort. Losartan sidesteps this entirely. It never touches ACE. Bradykinin continues to be metabolized normally. There is no accumulation, no lung irritation, no cough. The end result, lower blood pressure, protected blood vessels, reduced cardiac workload, is comparable to lisinopril. The efficacy is there, the kidney protection is there, the cardiovascular benefit is there, the loading dock is blocked, the factory is untouched, the goods never arrive. That's not just a cleaner mechanism, that is a fundamentally different patient experience. By the late 1990s, clinical trials are confirming what the mechanism predicted. The LIFE trial, Losartan Intervention for Endpoint Reduction in Hypertension, enrolls over 9,000 patients. It compares Losartan head-to-head against atenolol, another established antihypertensive. Losartan wins. Cardiovascular outcomes, stroke reduction, kidney protection, Losartan delivers. And it does it without the cough burden, without the bradykinin buildup, without the side effect profile that was quietly driving millions of patients off their medication. Doctors take notice, slowly at first. Lisinopril is still cheap. It is still familiar. 3 decades of prescribing momentum don't reverse overnight. A $4 copay doesn't get replaced by a newer drug just because the mechanism is cleaner. Inertia is a powerful force in medicine, and so Losartan grows, but it grows in the shadow of a giant. 35 million Americans are on lisinopril by the time the 2025 AHA guidelines are published. Losartan is second, widely prescribed, widely respected, but second. The numbers, though, are about to start telling a different story. A 30% cough incidence in a population of seniors who are already managing sleep disruption, fall risk, and cardiovascular fragility is not a minor footnote. It is a clinical emergency hiding in plain sight. researchers begin asking how many patients are stopping their medication because of the cough. How many are switching to nothing? How many are quietly going unmedicated because their doctor didn't connect the dots? The answers, when they come, are alarming. The bradykinin accumulation was a warning sign. Lisinopril's defenders ignored it. Everything Lisinopril had built was about to work against it. The clinic waiting room is full. It is a Tuesday morning in 2019. A 72-year-old woman named Margaret sits in the third chair from the door. She has been on Lisinopril for 6 years. Her blood pressure is controlled. Her cardiologist is satisfied. On paper, Margaret is a success story, but Margaret hasn't slept through the night in 4 months. The cough started quietly, a tickle at the back of the throat, a clearing that accomplished nothing. Nothing serious, nothing worth calling the doctor over. That is what Margaret tells herself. That is what most patients tell themselves. The cough is dry. It doesn't produce anything. It comes in fits, unpredictable, often at night when she is lying down and the house is silent and there is nothing to distract her from the sensation building in her chest. She has tried lozenges. She has tried humidifiers. She has propped herself up on 2 pillows and then 3. She has started sleeping in the recliner in the living room because lying flat makes it worse. She wakes at 2 in the morning, then again at 4, chest tight, throat raw, staring at the ceiling of a room that used to feel like rest and now feels like a waiting room for the next fit. She has seen her general practitioner twice. He ruled out asthma. He ruled out reflux. He told her to stay hydrated. Nobody asked about the Lisinopril. This is the pattern. Across thousands of clinics, across millions of patients, the ACE inhibitor cough is one of the most well-documented side effects in cardiovascular pharmacology. It affects up to 30% of patients on ACE inhibitors. In patients of Asian descent, the number climbs even higher, and yet it is routinely missed, routinely attributed to other causes, routinely undertreated. Because the cough doesn't show up on an EKG, it doesn't register in a blood panel. It is a symptom that patients minimize and doctors often overlook. Now, Margaret could have stopped there. She didn't. She returns to her cardiologist with a specific complaint. She has written it down on a notepad she carries in her purse. 4 months, dry cough. Worse at night, interfering with sleep. The cardiologist pauses, looks at the medication list. Lisinopril, 10 milligrams, daily. She has seen this before. She switches Margaret to Losartan. Within 3 weeks, the cough is gone. Margaret is sleeping flat again. The recliner is empty. The real question is what happened behind closed doors, because Margaret is not the exception. She is the rule. The 2025 American Heart Association guidelines report that Losartan shows a 40% lower cough incidence than Lisinopril in patients over 65. 40%. That's not a typo, by the way. That is a statistically significant, clinically meaningful reduction in one of the most common reasons seniors abandon their blood pressure medication entirely. And abandonment is the word that matters here. Cough is the #1 reason seniors discontinue Lisinopril. Not cost, not inconvenience, not a competing medication, the cough. And when seniors stop Lisinopril, the data shows they often don't switch to an alternative. They stop treatment altogether. The cough becomes the exit ramp off cardiovascular protection. Uncontrolled hypertension follows. Stroke risk climbs, heart failure risk climbs. A side effect that was never taken seriously enough becomes a cardiovascular event waiting to happen. Dr. Sarah Patel at the Cleveland Clinic has been direct about this. Her assessment, published in the context of the 2025 guideline discussions, is unambiguous. The cough is undertreated as a serious side effect. It drives non-compliance, which is the real cardiovascular danger, not the cough itself. What the cough causes, the medication gap it creates, the window of unprotected hypertension it opens in patients who are already at elevated risk simply because of their age. In seniors, the stakes of the cough are compounded in ways that younger patients don't face. Chronic coughing raises intrathoracic pressure. It strains the heart. In patients with existing cardiovascular disease, which describes a significant proportion of the over 65 population on antihypertensives, that strain is not trivial. Beyond the cardiac load, persistent coughing disrupts sleep architecture. Fragmented sleep in seniors accelerates cognitive decline, elevates cortisol, and worsens blood pressure control. The very condition lisinopril is treating gets harder to manage because the medication's side effect is undermining the patient's physiology at the most basic level. And then there is the fall risk. Seniors who cough chronically experience micro-episodes of balance disruption. Coughing fits at night lead to nighttime waking. Nighttime waking leads to nighttime bathroom trips. Nighttime bathroom trips in a senior with disrupted sleep and medication-adjusted blood pressure are one of the leading contexts for serious falls. Falls in patients over 65 are not minor events. A hip fracture in a 75-year-old carries a 1-year mortality rate of up to 24%. The chain of causation runs from bradykinin accumulation to cough to sleep disruption to fall to fracture to death. Each link is documented. Each link is preventable. The 40% reduction that Losartan offers is not a marketing statistic. It is a clinical lifeline. The same mechanism that built lisinopril's reputation as the gold standard was about to become its most damaging liability. There is a moment in the emergency room when the airway closes. It happens fast, faster than most people understand. The throat swells from the inside. The tongue thickens against the teeth. The soft tissue of the palate and the posterior pharynx begins to fill with fluid, pressing inward, narrowing the passage that air must travel through. The patient cannot swallow, cannot speak clearly. The voice comes out muffled as if the mouth is full of something that wasn't there an hour ago. And the patient who was fine an hour ago, who took a pill they have taken 1,000 times before, who had dinner and watched television and went to bed, cannot breathe. This is angioedema. And for seniors on lisinopril, it is the risk that lives beneath everything else. Angioedema is not common. That must be said clearly. The majority of patients on ACE inhibitors will never experience it. But lisinopril is the leading drug cause of angioedema-related emergency room visits in the United States. Not one of the leading causes. The leading cause. In a country where tens of millions of people take this medication, even a low percentage translates into a staggering absolute number of people presenting to emergency departments with swelling airways, with faces distorted by fluid accumulation, with tongues too large for their mouths, with physicians making rapid decisions about whether intubation is necessary before the window closes. And in patients over 65, the risk is 3 to 5 times higher than in younger adults. The mechanism is the same one that causes the cough, bradykinin accumulation. In the lungs, excess bradykinin irritates bronchial tissue and produces a persistent dry cough. In the soft tissues of the throat and face, it triggers a different response entirely. Vasodilation, plasma leakage through vessel walls, rapid dramatic swelling that can progress from mild discomfort to complete airway obstruction in under an hour. The older body clears drugs more slowly. Renal function declines with age. Hepatic metabolism slows. The result is that lisinopril and its metabolites linger longer in the elderly system, and bradykinin has more time, more opportunity to accumulate to dangerous levels. The same pharmacokinetics that make seniors more sensitive to blood pressure drops, the dizziness, the orthostatic hypotension, the falls, also make them more vulnerable to the most catastrophic manifestation of ACE inhibitor toxicity. The 2025 European Society of Cardiology position statement is unambiguous on this point. ARBs like Losartan are recommended over ACE inhibitors to minimize angioedema risk in elderly patients. The reasoning is direct. Losartan does not trigger bradykinin accumulation. It never touches the ACE enzyme. It blocks the receptor downstream. Bradykinin continues to be broken down normally. The inflammatory cascade that leads to angioedema has no fuel. The swelling has no trigger. The emergency room visit has no cause. The risk is not merely reduced, it is structurally eliminated at the mechanism level. Think about what that means for a 78-year-old managing 5 medications, living alone, whose nearest family member is 40 minutes away. Think about what it means that the standard of care drug for her blood pressure, The cheap one, the familiar one, the one that has been prescribed reflexively for 3 decades, carries a risk that is 3 to 5 times more likely to send her to the emergency room than it would her 40-year-old daughter taking the same pill. Think about the emergency room visit itself, the intubation risk, the ICU stay, the downstream complications in a body that no longer bounces back the way it once did, the pneumonia risk after intubation, the delirium that can follow an ICU admission in a patient over 70, the functional decline that begins in a hospital bed and sometimes never fully reverses, the family member who gets the call at 2 in the morning and drives 40 minutes not knowing whether their mother will be able to speak when they arrive, not knowing whether the woman who was fine at dinner, who took her pill with a glass of water and went to bed, will still be breathing when they push through the emergency room doors. The cough was undertreated, the angioedema risk was underestimated, and the prescribing inertia that kept Lisinopril at the top of the list for so long meant that millions of elderly patients were carrying a risk they didn't know they had, for a benefit they could have received just as completely from a drug that didn't carry it. We do not abandon Lisinopril. We do not condemn it. We do not erase 30 years of lives it protected and extended and saved. The drug is real. The evidence behind it is real. The patients who tolerate it well and whose blood pressure it controls effectively are real, and their outcomes matter. But we look at it clearly now. We look at who is taking it. We look at what their bodies do with it. We look at the swollen throat in the emergency room at 2 in the morning, and we ask whether that outcome was inevitable or whether it was a choice made by inertia dressed as medicine. The answer is not comfortable. But the next question, the one about kidneys, about hospitalization rates, about a 25% difference in outcomes, that question is where the conversation has to go next. Now you know the 25% difference. Subscribe.